Hello everyone. In this class, we'll try to learn about glomerular filtration. The learning objectives of this class would be to define glomerular filtration rate and give its normal value, give the normal values of hydrostatic, osmotic, pressure in glomerular capillaries and in Bowman's capsule, explain the mechanism of glomerular filtration, list the factors that affect GFR, list the chemicals that cause contraction and chemicals that cause relaxation of mesangial cells of the kidney, give the basic principles of measurement of GFR, list the conditions that alter GFR, and elucidate the mechanism of regulation of GFR. Glomerular filtration is the first step in the urine formation. This involves ultrafiltration of plasma that takes place through the glomerulocapsular filtrating membrane or filtering membrane. The product of filtration is called as filtrate, that is the ultrafiltrate of plasma that flows down the tubular lumen. The composition of the filtrate is altered as it passes through different parts of the tubule to finally become the urine. As the rate of filtration is the major determinant of tubular load, the final output from the tubule, that is the volume of urine, depends on the glomerular filtration. In general, factors that impair filtration decrease urine formation, and the factors that facilitate filtration increase urine formation. Therefore, determination of the glomerular filtration rate is an important test in the assessment of kidney functions. The mechanism of glomerular filtration. The glomerular filtration occurs through glomerulocapsular filtration barrier that consists of fenestrated capillary endothelium, basement membrane, and podocytes of capsular epithelium. And this is governed by two important major factors, that is pressure gradients or Starling forces, that is hydrostatic and osmotic pressure gradient across the glomerular capillary wall, and filtration coefficient that depends on the size of the capillary bed and the permeability of the capillaries. So glomerular filtration can be given as the Kf, that is constant, that is filtration coefficient, which depends on the size of the capillary bed and the permeability, into the pressure, the hydrostatic pressure difference between the glomeruli and the Bowman's capsule, minus the pressure, the osmotic pressure difference between the glomerulus and the Bowman's capsule. Okay. So that gives the glomerular filtration rate. Okay, so here Kf is a filtration fraction, as we said, the product of glomerular capillary wall permeability and the effective filtration surface area, where Pgc is the mean hydrostatic pressure in the glomerular capillaries, Pt is mean hydrostatic pressure in the tubule, and Pgc, that is supposed to be pi Gc, is the glomerular capillary oncotic pressure, and pi T is osmotic pressure in the Bowman's capsule or filtrate in the tubule. Okay, so here you can see the filtrating membrane, and this is the glomerular capillary, and this is the Bowman's capsule. Okay, so the hydrostatic pressure in the glomeruli is around 45 mmHg, and in the tubule, in the Bowman's capsule, it is around 10 mm of Hg. The pressure gradients. The pressure gradient across the glomerular capillary wall are different from pressure gradient along the capillary of other vascular beds. Therefore, the quality and degree of filtration are different through filtration barrier. Like other capillary beds, the pressure gradients are due to operation of Starling forces that are hydrostatic and oncotic pressures. Hydrostatic pressure gradient. The hydrostatic pressure in the glomerular capillary is considerably higher than the capillary pressure in the other parts of the body. This is because the afferent arterioles directly arise from the interlobar arteries, and they are short and straight. The glomerular capillary pressure at the afferent arterial end is same as the end of arteriolar end, so that is around 45 mm of Hg. and this pressure is opposed by the hydrostatic pressure in the Bowman's capsule, the tubule, so which is around 10 mm of Hg. Therefore, hydrostatic pressure gradient across the filtrating membrane is 35 mm of Hg. That is, the 45 is the arterial pressure, uh, the pressure in the glomerulus, and 10 mm Hg pressure in the Bowman's capsule towards the capsule. Thus, the hydrostatic pressure strongly favors filtration across the entire glomerular capillary membrane from its afferent end to the efferent end. Osmotic pressure gradient. The hydrostatic pressure gradient is opposed by osmotic pressure gradient. The osmotic pressure gradient depends on the glomerular capillary oncotic pressure and the osmotic pressure in the filtrate in the tubular fluid. The oncotic pressure at the arteriolar end is around 20 mm of Hg, and at the efferent arteriolar end it is increased and it is up to 35 mm of Hg. So this pressure is opposed by tubular fluid osmotic pressure. However, the osmotic pressure of the tubular fluid is negligible. Therefore, osmotic pressure gradient towards capillary lumen and the magnitude is more at the efferent end than at the afferent end. The net filtration pressure. The net filtration pressure, that is PUF, across the glomerular membrane depends on the difference between hydrostatic pressure gradient and glomerular capillary oncotic pressure. Okay, so as the oncotic pressure of the tubular fluid is negligible, so the filtration fraction, the filtration pressure is equal to the glomerular pressure hydrostatic minus the hydrostatic pressure in the tubule minus the oncotic pressure in the glomerular capillary membrane. At the efferent end of the glomerular capillary, the net filtration rate is 35 minus 20 mm of Hg, that is equal to 15 mm Hg, which is outward. And at the efferent glomerular capillary, the net filtration pressure is around 10 mm Hg, as at the efferent end the oncotic hydrostatic pressure increases 20 from 35 from 20 mm Hg. So that is why the filtration pressure will be 0. Thus, the net filtration gradient is always from glomerular capillaries towards the tubule, which is high at the afferent arteriolar end and that slowly declines to almost nil at the efferent arteriolar end. Filtration coefficient is the product of glomerular capillary wall permeability and the effective filtration surface area, that is the size of capillary bed. The capillary permeability, the glomerular capillaries are highly permeable, that is about 50 times that of capillaries in skeletal muscles. However, filtration depends on the size and the shape of the molecules and the electrostatic charge that they carry. The molecular size is an important determining factor of filterability of the substance. Neutral substances with molecular diameter less than 4 nanometer are freely filtered, and substances with a diameter more than 8 nanometer are not filtered. The elongated particle with a large molecular weight can pass easily, whereas globular particles of same molecular weight cannot pass through. The particles with positive charge can easily pass through the glomerular filtrating membrane than the negatively charged particles. This is because the glomerular capillary wall is negatively charged due to the presence of sialoproteins. Therefore, permeability of the cationic molecules is more than neutral and anionic molecules. The effective diameter of circulating albumin is less than 80 nanometers, but albumin is anionic. Therefore, normally albumin is not filtered through the glomerular capillaries. However, in diseases in which the charge of glomerular capillary is lost, as it occurs in glomerular nephritis, albumin appears in urine. Normally, about less than 100 milligrams of protein is excreted in the urine per day. This is not due to the filtration of proteins by glomerular membrane, rather due to the secretion by tubular cells. In fact, protein is not secreted, but it appears in the tubular fluid due to the shedding of tubular epithelial cells. Albuminuria, which refers to the excretion of significant amount of albumin in the urine, is normally absent. However, albuminuria is seen in the diseases in which there is an increase in the size of pores in the glomerular membrane, or there is a disruption of electrostatic force of glomerular membrane proteins. The surface area for filtration of the capillary bed depends on the size of the mesangial cells. The contraction of the mesangial cells decreases the area available for filtration, and relaxation of mesangial cell increases the area for filtration. Thus, the mesangial cell contraction impairs and relaxation facilitates GFR. So here are some of the factors that causes the contraction of the mesangial cells are angiotensin II, norepinephrine, endothelin, ADH, platelet-derived growth factor, platelet activating factor, histamine, thromboxane A2, prostaglandin F2, leukotrienes. Whereas some of the factors which causes relaxation of the mesangial cells are dopamine, atrial natriuretic peptide, cyclic AMP, prostaglandin E2, nitric oxide, and bradykinin. Glomerular filtration rate is defined as the amount of filtrate formed by glomerular filtrating membrane of both the kidneys in a unit time. Normally it is around 125 ml per minute, or 7.5 liters per hour, or 180 liters per day. Some of the factors affecting GFR are the change in the renal blood flow, the glomerular capillary hydrostatic pressure, change in the capsular hydrostatic, that is Bowman's capsule, oncotic pressure, glomerular capillary permeability, effective filtration of the surface area, size, shape, and electrical charge of the macromolecules. The GFR is influenced by factors that alter renal blood flow, pressure gradient, glomerular capillary permeability, and surface area for filtration. The increase in the blood flow to the kidney increases the delivery of blood to the glomerulus that promotes filtration, and conversely, decreased blood flow decreases filtration. Thus, the renal vasodilatation maintains GFR. The hydrostatic pressure in the glomerular capillary depends on the amount of blood delivered to and the amount of blood drained from the glomerulus. The afferent arteriolar dilatation or efferent arteriolar constriction increases the capillary hydrostatic pressure and therefore increases GFR. Conversely, the afferent arteriolar constriction or efferent arteriolar dilatation decreases GFR. Hydrostatic pressure in the Bowman's capsule and tubule opposes filtration. The tubular obstruction increases the tubular hydrostatic pressure and therefore decreases the GFR. Osmotic pressure in the glomerular capillaries due to the plasma protein opposes filtration. Therefore, hypoproteinemia results in more GFR. And conversely, the dehydration decreases the GFR and urine formation. Integrity of glomerular capillary is seen. Capillary is an important determinant of GFR. Increased capillary permeability increases GFR as it occurs in glomerulonephritis. The size of the filtration area depends on the mesangial cells. So mesangial cell contraction distorts the capillary lumen and decreases the area available for filtration. And conversely, relaxation of the mesangial cell increases the filtration. Many hormones and chemicals control GFR by altering the mesangial cell activity, as we discussed in the table. Size, shape, and electrical charge of the macromolecules determines the filtrability of the substances. Any substance having molecular weight less than 10,000 can be freely filtered by the glomerular filtration barrier, and molecules with weight more than 10,000 have a restricted filtrability. Most of the proteins in the plasma are larger molecules and therefore cannot be filtered. Also, the molecular shape influences the filtrability. Slender and supple molecules can easily pass through than the spherical and rigid molecules. Due to the presence of negatively charged particles in all the three layers of glomerular filtration barrier, molecules with negative charge cannot easily pass through, cannot be easily be filtered, whereas the neutral and cationic substance can do so. So here the filterability of different substances have been given. Water, glucose, inulin, they are 100% filtered, whereas myoglobin 75%, hemoglobin just 3%, and albumin almost it is not filtered. Filtration fraction is a ratio of GFR to the renal plasma flow. Normal filtration fraction ranges between 0.16 to 0.20. This is a better index of glomerular activity. For example, decreased blood pressure increases the filtration fraction without much changes in the GFR. In hypotension, renal plasma flow decreases. However, GFR decrease is less than the decrease in the renal plasma flow, as efferent arteriolar constriction maintains GFR. Thus, filtration fractions remain elevated. Coming to the measurement of GFR, they are usually measured by renal clearances. Measurement of GFR and the renal blood flow are based on the principle of renal clearance. Renal clearance of a substance is defined as the volume of plasma from which that substance is completely cleared or removed per unit time. When a substance is removed in urine, a certain volume of plasma is cleared of that substance. Therefore, clearance assesses important aspect of kidney function, as normally kidney is capable of clearing the substances from plasma. The clearance of a substance can be easily assessed by determining the concentration of substances in plasma and urine, and by estimating the urine flow rate. So the formula is clearance of substance X depends on the urine levels of that particular substance, the volume of the urine divided by the plasma concentration of that particular substance. So here the Cx is the clearance of the substance, Ux is the concentration of the substance in the urine, and V is the urine flow per unit time, and the Px is the concentration of substance in the arterial plasma. Urine clearance test. Inulin clearance test. Inulin clearance test is commonly used for assessment of glomerular filtration. It can be measured by measuring the concentration of substance in urine and the plasma concentration of the substance. The substance should be freely filtered through the glomeruli and should neither be secreted nor be absorbed by the tubules. The GFR is equal to the concentration of the substance X in the urine times the urine flow per unit time divided by arterial plasma concentration of the substance. So thus GFR can be given as Ux minus V divided by Px, where the Ux is the concentration of the substance in the urine, V is urine flow per unit time, Px is the plasma concentration of that substance. As the substance is not metabolized in the body of the body, the concentration in the venous plasma can be taken for the concentration of the arterial plasma. So this value of GFR is called as clearance of the substance. The criteria for the substance used: it should be freely filtered by the glomeruli, it should be neither absorbed nor secreted in the renal tubules, it should not be synthesized or stored or altered in the kidney, should not be metabolized in the body, it should not be toxic to the body, or it should be non-toxic to the body. Its concentration in the plasma and urine should be easily measured. The substance usually used is inulin, a polymer of fructose, as it meets all the criteria of ideal substance for measuring GFR. It is injected intravenously initially as a bolus dose and then through the continuous infusion to maintain a constant concentration in the arterial plasma. Once the inulin equilibrates with the body fluids, the urine and the plasma sample are collected for its estimation. For example, if urine concentration is 40 milligrams per ml, the plasma concentration is 0.25 milligrams per ml and the rate of urine flow is 0.8 ml per minute, then the clearance of inulin will be around 128 ml per minute. As the inulin is neither absorbed nor formed or altered nor stored in the kidney, the filtered load of inulin equals to the rate of inulin excretion. Therefore, inulin clearance equals GFR. Creatinine clearance test. Endogenous creatinine clearance is used clinically to estimate GFR. Creatinine is the end product of creatine phosphate, a skeletal muscle derivative. It is produced continuously in the body and excreted continuously in the urine. Therefore, the concentration of creatinine in plasma and urine are normally stable. The concentrations are measured in plasma and urine flow rate is determined, that is the volume of urine formed per unit time, and then creatinine clearance is calculated as clearance of creatinine is equal to the plasma levels of urine, the urine levels of creatinine into the volume of urine divided by plasma concentration of the creatinine will give you the creatinine clearance. The advantage are that no infusion of creatinine is required. Some of the conditions that are going to alter the glomerular filtration rate. So it can be exercise, pregnancy, posture, sleep, weather, gender, age, food intake, all these conditions they're going to alter the glomerular filtration rate. GFR changes in the different physiological and non-physiological conditions. When it is going to change in different physiological and non-physiological conditions. The changes are due to the change in the renal blood flow, glomerular oncotic pressure, glomerular hydrostatic pressure, and change in the plasma protein concentration, etc. GFR in exercise, GFR decreases due to the sympathetic stimulation that causes more afferent arterial constriction than constriction of efferent arterioles. In pregnancy, the renal blood flow and GFR increase. The renal blood flow increases due to the increase in the blood volume, cardiac output, and increased renal vascular resistance. The GFR increases mostly secondary to increase in renal blood flow. However, hormonal changes also play a role. About 40 to 50% of the increase of GFR occurs in second and third trimester of the pregnancy. Maintaining body in a standing position for a longer duration decreases the GFR due to the sympathetic stimulation and decreased effective blood volume, that is pooling of the blood occurs in the vein of the lower limbs and abdomen during standing position. Conversely, the supine posture increases the glomerular filtration rate. GFR is usually less during sleep due to the decreased circulatory activity. However, supine position maintains the GFR. GFR is more in rainy season and less in summer. In summer, decreased ECF volume decreases GFR. In winter and rainy season, GFR is more due to the decreased loss of water from the body and less humidity. GFR is less in females than compared to males. GFR decreases in geriatric age group due to the functional loss of nephrons. GFR is also less in case of children. The diet rich in protein increases the GFR. Regulation of GFR. Usually the factors that affect the renal blood flow also affect the GFR. Thus, the regulation of the glomerular filtration involves neural mechanisms, hormonal mechanisms, myogenic mechanism, and tubuloglomerular feedback. Neural mechanism. Both afferent and efferent arterioles are innervated by the sympathetic fibers. The sympathetic activity in the renal nerve is less when the blood volume is normal. When blood volume decreases, increase renal sympathetic activity and increase circulating catecholamines cause renal vasoconstriction that in turn decreases the renal blood flow and GFR. Activation of the sympathetic fibers causes constriction of the afferent arteriole that decreases blood flow to the glomerulus and therefore decreases the GFR. Thus, sympathetic stimulation as occurs in emotion, fear, pain decreases the GFR. Hormonal mechanism. Various hormones affect GFR. These include angiotensin, histamine, dopamine, ANP, endothelin, bradykinin, nitric oxide, adenosine, glucocorticoids, and prostaglandins. Angiotensin 2 causes the constriction of the afferent and efferent arterioles. However, the effect of afferent arteriole is more than on the efferent arteriole. Therefore, it decreases the GFR. The release of histamine locally plays an important role in control of GFR. Though histamine causes arterial dilatation and increases renal blood flow, however, by causing contraction of the mesangial cells, it decreases the GFR. Dopamine usually causes a renal vasodilatation. Atrial natriuretic peptide is released when there is increased blood volume. Endothelin is a potent vasoconstrictor. Nitric oxide is nothing but the endothelial derived relaxing factor, and it causes profound increase in the GFR. Bradykinin is a potent vasodilator. It stimulates the release of nitric oxide and prostaglandins, thus it increases GFR. Adenosine causes constriction of the afferent arteriole and therefore decreases the GFR. It also plays a role in tubuloglomerular feedback. Glucocorticoids increase renal blood flow and GFR, but the mechanism of alteration of GFR by glucocorticoids is not clearly known. Prostaglandins are formed and secreted by the kidney. They increase renal blood flow by decreasing the vasoconstrictor effect of catecholamines and angiotensin 2. Prostaglandin E2 causes relaxation of the mesangial cells that contributes to increase in GFR. In conditions like hypotension and shock, prostaglandins play important role in regulation of GFR. In hypovolemic shock, sympathetic activation causes renal vasoconstriction, which deteriorates the kidney functions. However, renal vasodilatation effect of prostaglandin in shock protects kidney by opposing the sympathetic constrictor activity and maintaining renal blood flow. Then autoregulatory mechanisms. Similar to autoregulation of renal blood flow, GFR is also autoregulated. The autoregulation of the GFR maintains a constant rate of glomerular filtration despite of changes in the systemic arterial pressure within 80 to 180 mmHg. So this is mainly due to the myogenic theory and theory of tubuloglomerular feedback. Okay, so that's why the GFR is maintained within a normal range, the blood pressure in between 80 to 180 mm of Hg. The myogenic mechanism controls renal blood flow as well as GFR. When arterial pressure increases, the afferent arteriole is stretched, and stretch-induced contraction of the smooth muscle of afferent arteriole decreases the GFR. The opposite mechanism operates in hypotension. Tubuloglomerular feedback. Increased renal arterial pressure increases pressure in the glomerular capillaries. This increases the GFR and flow of fluid in the tubule, which is sensed by macula densa cells. The tubular cells provide signal to the glomerular apparatus that causes afferent arteriolar constriction to decrease GFR and bring back it to normal and maintain the constancy of load delivered to the tubule. Okay. This is called as tubuloglomerular feedback. The exact mechanism of macula densa cells sensing and then signaling the juxtaglomerular apparatus is not clearly known. However, it is now clear that macula densa senses the flow-dependent changes in sodium chloride reabsorption. The likely mediator are the adenosine and the nitric oxide. So this is in brief about the glomerular filtration and the factors which are going to affect the glomerular filtration. Thank you.